Okay, great. Let's get rolling here. Thanks very much for the opportunity to present here today. I have a bunch of stuff I want to take you through, and hopefully we can have some time at the end for questions. So my disclosures are I'm a member of a research group which has a policy of not accepting honorariums or other payments from industry for our own personal financial gain. We do accept honorariums or payments from industry to support research endeavors and reimbursement of costs to participate in meetings. Most of the research that I've undertaken has been funded by peer-reviewed groups. However, I have originated questions and I've written grants which have been funded by industry, including Abbott Diagnostics, AstraZeneca, Bayer, Boehringer Ingelheim, Bristol Myers Squibb, Covidien, Roche Diagnostics, and Stryker. What's most relevant for you is that I'm going to spend a lot of time talking about troponins and perioperative troponins. The research I'll be talking about was overwhelmingly funded by peer-reviewed grants. We had over 65 international funding sources. However, Roche Diagnostics did provide the troponins and a small amount of money. And we're about to start now a large study with Abbott Diagnostics in the cardiac surgery setting, repeating what we've done now in the non-cardiac surgery setting. So that's most relevant, and I'm going to talk to you about Poise 2 very briefly, and that's funded primarily by the Canadian Institute of Health Research, but we also have some funding from Boehringer Ingelheim, and Bayer is also providing this aspirin. Okay, so the goals of my presentation are, I first want to review for you the prognostic relevance of perioperative troponins. I want to then discuss a new concept that our group is advocating. We're advocating in the perioperative period to move away from the concept of myocardial infarction and to move to the concept of myocardial injury after non-cardiac surgery, which we call MINS. I'll explain why later on in the talk, and you can let me know if it makes sense and resonates with you. We're then I'm going to review evidence around whether or not, in fact, we can prevent major perioperative vascular complications. And then I'm going to talk about how can we actually manage these events if they do occur, and tell you about the first large trial that we just initiated on how to treat these events when they actually do occur. The reason as a cardiologist that I'm personally very passionate and interested in the area of perioperative vascular medicine is that globally now there's over 200 million adults having major non-cardiac surgery every year, and it's growing. And it continues to grow in the elderly. And in fact, what we're seeing is that the incidence of major vascular complications is rising, and I want to make one point really clear about this, is that that's happening despite the fact that anesthesia and surgery has become safer. It is driven by a single factor, which is the age of patients. I'm going to show you a lot of data a little later on that will overwhelmingly show you the complications are now being driven because you're doing surgery on much older patients with much higher burdens of underlying vascular disease, and that's why we're seeing a substantial increase in the complication rates. Despite this really being a huge population problem, it still is a neglected area, and I think that there's a whole lot of room for potential improvement in helping these patients to have better outcomes and enjoy the benefits of their surgical anesthetic interventions that they're actually having. One of the goals of the VISION study was to determine among patients undergoing non-cardiac surgery the relationship between postoperative troponin T and the risk of 30-day mortality. The VISION study is a prospective international cohort study. To be eligible, patients only had to be age 45 or greater undergoing in-hospital non-cardiac surgery. So one thing that's important to keep in mind when I show you the results is that we weren't selecting out high-risk patients, we were selecting all comers. But importantly, it was a representative sample. We had in place mechanisms to ensure that we would both capture a representative sample of elective and urgent emerging cases, day and night cases, weekday and weekend cases. So it's meant to be more reflective of what is the reality that happens with all of our surgical cases right now. And this does include data that also comes from the States, but it's a global study with representation from all of the inhabited continents. Participating countries: North, South America, Europe, Asia, Africa, Australia. Sample size 40,000 patients. After the first 15,000 patients, our event rate was actually 3 times higher than we expected. So at that time, we knew that we had enough information, because we had enough events, to answer the question about the relationship between the postoperative troponin T and 30-day mortality. And because the reality is the world is moving to high-sensitive assays, we then made a decision strategically at that point that we would switch from using the non-high-sensitive troponin T assay to the high-sensitive trop T assay and publish the results on the non-high-sensitive trop T results, which is what I'm going to show you today. In America, you're still using the non-high-sensitive trop assay. In most of Europe and a lot of the remainder of the planet have now switched over to using the high-sensitive assay. In the study, patients had troponin T measured 6 to 12 hours after surgery, day 1, 2, and 3 after surgery. Now, when we did this study, what labs would tell you is that with a fourth generation troponin T, that a value of 0.04 or greater was what was abnormal. And this was based upon a measure of precision, a coefficient of variation that is equivalent to 10%. Now, importantly, when people first started discovering troponins, they first said, okay, how are we going to decide what's an abnormal troponin? And what they did was they took people walking around healthy, happy in the community, 40 to 50 years of age, they measured troponin. And they said anything above the 99th percentile of a healthy, happy population is what's abnormal. People then did research where they say, okay, people come to the emergency room with potential ischemic symptoms. Do people who have a value above that or greater do worse than people below that? And as you predict, they do in fact do worse. But one of the quick problems people instantly discovered was there was way too many people, according to cardiologists, who had positive troponins. Way too much work. So what lab medicine then said is, well, we realize there's also imprecision in the assays, and this 99th percentile has it so that so many people are positive. What we'll do is we're going to choose a value around precision because we know it's a higher value than the 99th percentile, and they chose the coefficient of variation of 10%. Now, to start with, people could have chose a 97.5% confidence interval for the population. Could have chosen 98. And when it came to the coefficient of variation, they could have chose 12, could have chose 8. It's arbitrary. People chose 10. And then when you do studies when people show up and emerge and you say, do people above that value do worse? And as you predict, of course they do worse. That doesn't mean it's the right threshold, because that's where 0.04 comes from with the troponin T. So it has a coefficient of variation of 10%. So say here is a value of 0.04. It is possible that the signal of all the bad outcomes is driven by people way above 0.04. At the same time, it is also possible that, in fact, some people directly below 0.04 are doing poorly, but that signal gets washed out by all the people way below 0.04 who do incredibly well. So the point I'm making is that the approach we've had, both in cardiology and lab medicine, into determining what is an abnormal troponin has a lot to be desired. In fact, it is fundamentally arbitrary, and then with a limitation to how we have actually tried to prove that this is what's abnormal. In vision, we wanted to avoid that fundamental problem, and the main reason why that limitation existed is that most people didn't have large enough studies with a single assay to figure out are there actual thresholds where risk is actually changing. There's over 13 different troponin I's, there's one troponin T, and now within assays you now have high sensitive assays and you have non-high sensitive assays. And all these assays have different thresholds and different meanings of what should be abnormal. So to a certain extent it was much easier for guideline committees to say we're going to have a threshold that corresponds to the coefficient of variation of 10% for every assay, because you then don't have to figure out are there actual variations across the assays. I do think that almost all the troponins predict. I just think that from our research it's unlikely that these arbitrary thresholds, 99 percentiles, coefficient of variation of 10%, have the same prognostic meaning on these assays across these assays. So our approach was we wanted to have a large enough study with a single assay that we could actually use the actual data to figure out are there actual places where risk, independent of everything else, is changing to alter that patient's prognosis. So to determine this, we were interested in looking at the dependent variable being 30-day mortality. So that's what we're trying to predict. It's not the only thing that matters, but clearly it matters a lot to patients. And if there are troponin values which alter the likelihood that people are going to die in a short period of time, clearly those are values that do matter. For this first analysis that I'm going to show you, this is a paper that we published in JAMA last June. In this paper, what we did was we first took into account 24 preoperative and surgical variables, so age, history of diabetes, history of coronary disease, type of surgery, urgent, emergent, traditional things you'd think of. And then what we did was we added in the peak troponin in the first 3 days after surgery. But what we did was we used statistical approaches without making assumptions about what's an abnormal troponin to explore all of the potential troponin thresholds to see if there are any which statistics can confidently tell us there is no doubt that at that level the risk independent of everything else is changing. So that's the approach that we used. So during the period when we were recruiting patients with the fourth generation troponin T, this happened between 2007 and January 2011. During that period we recruited just over 15,000 patients. The median number of troponins measured post-op was 3. Of these 15,000 patients, only 40 patients didn't complete the 30-day follow-up. That is 99.7% did. Those 40 patients we censored on the day of discharge because that's the last time we knew about their vital status. This slide shows you a very important point, which I'm going to come back to a little later on in the talk. Essentially now, 1 in 4 people are age 75 or greater having major in-hospital non-cardiac surgery. And it's relatively consistent across the planet. It is certainly less in Asia, but it's not dramatically less. And this is what overwhelmingly I'm going to show you later on is driving the signal of increased vascular complications. It is the age of the patients and the comorbid disease that it brings with the age. But we're currently doing surgery on patients who 15, 20 years ago would readily not be being considered for surgery. And in today's world, it's no big deal to be in your 80s and even in your 90s and going for major non-cardiac surgeries. This is what we found in the analysis when we adjusted for the preoperative variables and surgical variables in terms of the prognostic relevance of troponins. Instead of 0.04 being the value that actually mattered, it actually appeared that 0.01 or less was actually what was truly normal. Now importantly, 88% of people who are age 45 or greater, that will be their peak troponin. So the majority of patients, that will be their peak. Their risk of death at 30 days is 1%. 0.02, a value that no cardiologist, no internist would ever consider abnormal, was an independent predictor that that patient was going to die in the next few weeks. Just 3% of those patients, 3% of patients that will be their peak, and their risk of death rose to 4%. 0.03 was the next threshold, and by statistical approach, 0.03 is the threshold which, in fact, we are absolutely most confident about where you're altering risk. So 0.03 to 0.29, we did not see any differences within that range. It is certainly possible that there's another threshold in there, and even with a bigger sample, there might be another cut. But I can tell you with reasonable confidence, 0.03 is unequivocally no different from 0.04, and it's almost for certain no different than 0.1, but maybe up around 0.2 there's another jump. But in that category, where about 7.5% of your patients age 45 or greater will actually fall, their risk of death is actually going to rise to 9%. So 1 in 11 of those patients will be dead in a 30-day period. The final threshold that we established was 0.3 or greater, and roughly about 1% of patients that will be their peak troponin in the first 3 days after surgery, and their risk of death jumps to just under 17%. So just over 1 in 6 of those patients will be dead in a 30-day period. The timing of death is such that the smaller the initial insult, the longer the period of time to death. And the point I want to make clear is that a troponin of 0.02, 0.03, 0.1, 0.2, these are not massive heart attacks. What these are is profoundly important warning myocardial insults, and they set patients up for a very bad event coming in the coming weeks. So the lower your initial troponin, the more time you have before, in fact, you have the major event. So at 0.02, the median time to death was 13.5 days. At 0.03 to 0.29, it's 9 days. And at 0.3 or greater, it's 6.5 days. Importantly, of the patients who would die in the first 30 days after surgery, 1 in 4 of them would die after hospital discharge. Many of these patients had elevated troponins that people thought didn't matter. These patients were discharged home, and then 1 to 2 to 3 weeks later would have a massive event, and these patients would unfortunately would die. This, we believe, an appreciable proportion of this is modifiable, and that's our goal, to actually change that outcome for these patients. We certainly owe it to patients from the point of view of some patients are getting cures of cancer, some are getting a new lease on life with a new hip or knee. It's a tragedy to suffer a cardiovascular event that is not appreciated to even happened, not to intervene upon it and have the patient die in the short term. As I mentioned earlier, we're recommending to move away from the concept of myocardial infarction and to move to the concept of myocardial injury after non-cardiac surgery. But the reason that we're advocating this is that some prognostically relevant myocardial insults in the perioperative period may, in fact, it's a fact, they don't fulfill the universal definition of myocardial infarction. So within cardiology and internal medicine, we use what's referred to as the universal definition of myocardial infarction as very specific diagnostic criteria. Many of the events, and I'll explain why it happens in a moment, in the perioperative period don't fulfill those criteria, yet in fact clearly are myocardial injuries that have prognostic relevance to these patients. Further, these injuries may almost a large proportion represent injury as opposed to necrosis. The definition explicitly of myocardial infarction is that you have myocardial cell necrosis, which frequently in cardiology we actually can't prove. And it's almost for certain that some of these events represent injury and not actual necrosis. It may minimize the risk of assuming what is known about non-operative MIs applies to these outcomes. It may avoid the labeling and implications such as insurance and employment, which is really from the term myocardial infarction based upon data in the non-operative setting. And hopefully it may bring focus and attention on a topic that is relevant. So those are the reasons why we're advocating to move to a new concept of myocardial injury after non-cardiac surgery, which we call MINS. Our proposed definition for MINS is the following. It is myocardial cell injury caused by ischemia that may result in necrosis, but it may not, has prognostic relevance, and occurs during non-cardiac surgery and within the first 30 days after non-cardiac surgery. That period of time looks to be unique when, in fact, if patients don't suffer an event within that time, it appears that most patients are reverting back to whatever their normal risk levels are. If you do suffer an event in that time, it changes everything in terms of your prognosis. Importantly, MINS does not include perioperative troponin elevations due to a documented non-ischemic cause. That is, that the patient has a pulmonary embolism, sepsis, a known chronically elevated troponin, the patient gets cardioverted. So there's something else other than ischemia to explain it. We are not counting that in the MINS category. It's one thing to propose a definition for something. The real issue is, how do you establish diagnostic criteria for that definition? And our approach to doing that was to develop diagnostic criteria through exploration of various criteria based upon an assumption of underlying shared pathophysiology. So in other words, we would look at all the troponin elevations, have two people independently review each case, remove any case where they felt that the troponin elevation was due to a non-ischemic etiology. So we're only trying to keep in the ones that we believe are due to an ischemic etiology, and then demonstrate its prognostic relevance through seeing whether or not that diagnostic criteria, independent of everything else, impacts mortality at 30 days, with a caveat that I'll explain in one moment of how we did this compared to the first analysis I showed you. So our approach is the following. Once again, the dependent variable, the variable we're looking to predict, is 30-day mortality. The independent variables included the preoperative and surgical variables that were independent predictors of death in the first analysis that I discussed. And then we put in time-dependent postoperative variables. So now we're putting in the other postoperative complications, so pneumonia, DVT, infection. And we also include, or stroke, we also include sepsis and PE as long as that sepsis and PE is not associated with an elevated troponin. If the sepsis and PE is associated with an elevated troponin, they're removed because we don't want to muddy the waters with what represents myocardial injury. So now the reason that we're doing this is that just imagine that everyone who gets troponin elevation after surgery and has quote-unquote, we believe, myocardial injury, and we show there's a relationship to death, as we showed in the first analysis. But imagine that the only one of those patients who die are people who get pneumonia on day 9, and it's really pneumonia that kills them. Well, then if that's the case, we want to put our focus on the pneumonia because that's what matters. So we really want to know that, is this myocardial injury, independent of the other complications happening, is this a dominant one that's driving the signal of death, and it's not confounded with the other complications that are happening in the perioperative period? There ends up being, in the first 15,000 patients, 1,300 patients who have elevated troponins. In the adjudication of these 1,300 patients, only 99 of them are excluded because their troponin elevation was felt due to a non-ischemic etiology. So the point I want to make is that it appears, to the best of our capacity to do this, the vast majority of people that get elevations of troponin after surgery appear to be due to myocardial injury. Now, we had a process whereby people who have elevated troponins, they end up being seen, they have to get ECGs for a couple of days. If they don't have any symptoms, any ECGs, we push people to get echoes. We probably got echoes on about half of them. And on the echoes, we're looking to see, is there a wall motion abnormality or evidence of right-sided strain that might suggest a pulmonary embolism, because we want to make sure we're not missing pulmonary embolism in these cases. And just to tell you that in that process, it appears to be a trivial number of the events can get attributed to non-ischemic etiologies. The vast majority seem to fall into ischemic etiologies. So this is what we found in this adjusted model. So once again, we're adjusting for the preoperative surgical variables and the other postoperative complications. So the various variables we explored within the potential diagnostic criteria for MINS. The first one was a peak troponin of 0.04 or greater with clinical features. So what these ischemic clinical features include is ischemic symptoms, chest pain, shortness of breath, pulmonary edema, arm, neck, jaw discomfort, anything like that, or ECG changes showing ischemia. So ST, T-wave changes, new Q waves, anything like that. Now the reason that we used 0.04 was that when we started the study, we in fact did not anticipate that values below 0.04 would end up being important. So patients were only getting ECGs and being assessed for ischemic symptoms if in fact the troponin was 0.04. In fact, most people in the study thought that 0.04 was not relevant. In fact, as I said, most people didn't really think till 0.08, and I certainly did not think 0.04 was relevant. So we couldn't explore below that because we didn't know whether or not at 0.03 or 0.02 people did or didn't have ischemic features. We also put in first in this analysis 0.04 or greater without ischemic features. So these are patients who had troponin elevation. There's no evidence of a non-ischemic etiology, but there's no ischemic symptoms and there's no ECG changes. If that independently predicted death at 30 days, we then were going to repeat the model, add in the 0.03 and the 0.02 without knowledge of whether or not they have ischemic features. The reason being is that that would actually demonstrate you don't need ischemic features. And what we see here is that that is the case. So in other words, at 0.04 or greater with clinical features of ischemia, either ECG changes or symptoms, there's almost a 5-fold increase independent of other complications, preoperative variables, that that patient is going to die in a 30-day period. But most importantly, at 0.04 without ischemic features, that independently is altering the likelihood that patient is going to die. It's over a 3-fold increase. Now, in retrospect, this is not surprising. As I'll show you in a moment, because the vast majority of these events happen in the first 24 to 36 hours after surgery when people are getting analgesic medication, the vast majority of people will not experience ischemic symptoms. And the problem with the ECG is that it appears clear from Holter studies that the vast majority of people do have, in fact, ECG changes. But the problem is we're not being triggered to do the ECG when they're actually having the event. We're just routinely doing troponins, picking up the elevation, and then doing an ECG, which frequently is 12 to 24 hours after the ischemic event started. So in fact, you're missing the ECG changes. Then the problem that happens in clinical medicine, people get lulled into a false sense of security. There's an elevated troponin which people think they're not so sure that it's that high or it matters. Patient has no symptoms and no obvious ECG changes. And the reason is they were masking the ischemic symptoms and we've missed the ECG changes. It doesn't mean that they're not there. 0.03 ends up being an independent predictor and 0.02 was no longer an independent predictor when we took into account the other postoperative complications. Based upon this, our proposed definition of MINS is a troponin T of 0.03 or greater that is believed due to an ischemic etiology. That is, there's no evidence to suggest a non-ischemic etiology. Now, there's no doubt that there may be some events that sneak through where, in fact, there was a non-ischemic etiology, but to the best of our capacity to assess these patients, it appears that there's a minority of patients that will be into that category. This is from this model that I've been talking about, and this is showing you just the preoperative and surgical variables, and I want to make a point about something on this slide. I'll show you the results of the postoperative complications, which ones predict death on the next slide, but they're all in the same model. So the way that this table is set up is that the first column shows you the independent predictors of death at 30 days. The second column shows you the incidence of each one of those risk factors. The third column shows you the adjusted hazard ratio, and the final column shows you PAR, which stands for population attributable risk. Now, I would advocate to you that population attributable risk is the most important statistic you should focus on. And the reason is that sometimes you have a risk factor which has a really high hazard ratio, or you have a risk factor where there's no doubt if you get it, you're going to die. But the reality is 1 in a million people get that risk factor. So in reality, from a population point of view, that risk factor explains almost nothing to us. You really want to know how common the risk factor is along with its strength of association to figure out if, in fact, this risk factor is causal, how many of the deaths may be associated to that risk factor. Okay? So population attributable risk takes into account both the strength of association and how common the risk factor is. And what I want to draw your attention to is if you look at age is if you look at the preoperative surgical variables, it is the dominant association to death at 30 days. It potentially looks like it could explain 42% of the deaths. Now, to be clear, age doesn't kill you. It's the comorbidity that goes along with age, which then results in complications. So none of these things kill you. It's what they cause that kills you, outside of cancer. Cancer, in fact, can clearly kill you postoperatively. But for the most part, these other things do not kill you postoperatively. They lead to complications that kill you. And with age, the real reason why age is so dominant is that it's the advanced age of patients which is actually resulting in these complications and resulting in severe underlying comorbidity. But the bigger problem, which is another issue I'm not going to address today, but it's a really big problem, is that the reason why age shows up here is that we actually have a difficult time actually establishing the comorbidity in a lot of patients. The problem that we have when we see people pre-op and we say to them, do you get chest pain, shortness of breath, and they say no, the problem is most of those patients are profoundly inactive. Many of those patients have significant underlying coronary disease, But all of the orthopedic patients, the vascular patients, the cancer patients, they do very limited activity for 6 to 12 months before their surgery. And so we get lulled into a false sense of security. They must not have disease because they're having no symptoms. But the problem is, it's just because they're inactive. If, in fact, we had better ways to identify the comorbidity, age would drop down. It would then shift over to the comorbidities. But it is age that's driving all this comorbid disease, which causes the actual complications. Of the complications that we explored, the ones that did, independent of everything else, predict death are the following: MINS, sepsis, stroke, and pulmonary embolism. And when you look at the population attributable risk, what you'll notice is the two overwhelming postoperative complications that drive death are MINS and sepsis. If we're going to put our focus onto something to change the outcome for our patients from a death point of view, overwhelmingly that's where our focus needs to go, because that's what's killing patients. So up to a third of the patients are dying from myocardial injury, and just under a third are dying from sepsis. Now, the thing about sepsis is, when sepsis happens, eventually people identify it and everyone treats it. With myocardial injuries, I'm going to show you in a moment, to a great extent, it's not identified, and even when it's identified, for the most part, it's ignored. I still believe we can make advances in terms of sepsis, and how I think we can make advances in terms of sepsis is that sepsis tends not to be diagnosed till day 6 to 7 after surgery. For certain, the vast majority of patients have the seeds of sepsis laid much, much earlier than day 6 to 7 after surgery. What we're doing is we're trying to explore whether or not we can identify markers on day 1 to 2 to 3 after surgery, which can identify a patient that's at really high risk that they're going to become septic, to then ultimately do trials where we'd actually start those patients being randomized on antibiotics at that time, well before it's even obvious that they are infected or septic, compared to waiting to see whether or not, in fact, they develop full-blown sepsis and treating them at that time. So I believe we can bring down sepsis, and I profoundly believe we can bring down MINS death. And the reason I believe that is if you look at pulmonary embolism. Pulmonary embolism potentially is only accounting for about 3.5% of the deaths that happen in the perioperative period. Now, pulmonary embolism is a big deal if you get it. Its hazard ratio in terms of death is 6-fold. So if you get a pulmonary embolism, there's a 6-fold higher likelihood you will die in a 30-day period. So it is a big deal if you get it. But the reality is the event rate is plummeted. And for the most part, pulmonary embolism in the venous side is the only place we've made real advances in perioperative medicine. We now have, in general, very effective VTE programs which have plummeted the incidence of VTE and pulmonary embolism, and that's why now it accounts for very few of the deaths, because it's so uncommon. If you went back 20 years ago, that would be, in fact, much, much higher in terms of the population attributable risk. And that's what I hope we can now do on the arterial side if we make the same kind of focus and same amount of research that has happened on the venous side to plummet down the impact of the arterial side, which is now explaining a dominance of the deaths that we're seeing in the first 30 days. This shows you the impact of MINS for death, but for other things. So this is looking at the second column, patients who didn't suffer MINS, and the third column, patients who did suffer MINS, and then it's showing you the odds ratio. And what you can see is that when you look at non-fatal cardiac arrest, heart failure, stroke, mortality, basically there's a 5 to 15-fold increase if you have MINS, that you'll also have one of those complications in the first 30 days. And if you look at a composite of all those, it's 2.4% of the people who don't get MINS, whereas it's just under 19% of the people who do get MINS. Another issue is, I've been focused so far on the first 30 days. It appears that even if you survive the first 30 days, it doesn't mean that you're out of the woods. In other words, if you get myocardial injury, you're still remaining susceptible, it appears, to death in the coming year. So this is a meta-analysis that we published a few years ago, and it was studies where people were followed beyond 30 days. And these were studies where people had troponins being measured perioperatively, and then they tried to risk adjust for what they could to see about what will predict mortality in the first year. And what you see is that even beyond the first 30 days, there's still a 6-fold increase in the likelihood those patients will die if they have an elevated troponin after surgery. And what we believe fundamentally happens is that with these initial events, they're essentially warning myocardial insults, which may change plaque morphology and susceptibility to rupture weeks to months down the road, which in fact can then result in major events which patients can die from. If we can intervene, there's lots of reason to believe that in fact we can stabilize those plaques and prevent some of those events from actually happening. Now, I've just made a big deal saying perioperative vascular events and myocardial injury is a big deal. So a question is, can we prevent it? I think there's no doubt we can prevent it, but we're still really in the early days of understanding how we can safely prevent it. So one of the issues is statins. The problem fundamentally now with the statin data is that overwhelmingly it came from Don Polderman's group, and now there's a whole bunch of questions about all the studies. There's very limited data on terms of the statin data. Maybe it works, maybe it doesn't. It's probably a very low risk in terms of giving it to patients. There's not a whole lot to suggest that, in fact, there's harms by it, but it's far from being clear that it truly works. So at the moment, despite what a lot of people are saying that there's really strong evidence for statins, it is pretty weak evidence for statins. It's overwhelmingly observational data, which may or may not be true, but we need a larger trial. I think it'll be a very tricky trial to do, and the reason I say that it'll be a very tricky trial, and as a group, and I'm going to tell you about Poise 2 and Poise 3 in a moment, but the reason why we haven't tackled a statin trial is that the problem is there's like 60+% of the patients are already on statins who you consider studying. So it's a challenging trial to do because most people are on statins. The second thing is that I fear that if you do the trial, it's not realistic in a global context to do a trial where you say, I'm going to start a statin a week or 4 weeks before surgery. Perioperative care globally is not set up that way. There may be unique centers where you can do that, but it's very uncommon. Most centers are set up where patients are seen in the pre-op clinic days to a week at most before surgery. So you're going to look at starting the statin on the day of surgery, and I just worry that if we start on the day of surgery it doesn't work, everyone will just claim the reason it doesn't work is you didn't start it weeks or months before, which may or may not be true, but I think it'll be a very challenging trial to do, but we do need a trial on statins, but I predict it's not going to be simple to actually pull off. I spoke earlier today about beta blockers. There is absolutely no doubt that beta blockers do have clear benefits. They clearly prevent myocardial infarction, myocardial injury. There's absolutely no doubt about it, and I just made a big deal saying myocardial infarction and injury is a dominant pathway through which people are dying. So it's clear that controlling the sympathetic system is beneficial. The problem, as I expressed earlier today, is that it's not clear that we know how to do it safely yet. It'd be one thing if you're going to, as I said, run esmolol through the case and put them in the ICU and run esmolol and turn them off as soon as they become hemodynamically compromised. I suspect you'll likely get the benefit, avoid the risks. The problem is beta blockers on surgical floors, patients getting hypotensive, long delays in picking it up, poorly being managed. That's what gets patients in a serious complication. And as I said, I think one of the risks about perioperative medicine is that it's fragmented. Anesthesia is overwhelmingly involved in most cases in the OR and the PACU, and they're not seeing the complications that happen under their vision back 2 days later on the surgical floor. So just because you've never seen a major stroke in front of you, which I suspect is true of most of you, that doesn't mean that it's not happened. It doesn't mean that it doesn't happen. And that's the thing we have to be cautious about. And we either have to find ways to change the system of better management on floors and better monitoring, which I think is potentially feasible, or we find a different way to deliver it or a different agent where we can get the benefit and mitigate the risk. In terms of clonidine, perioperative RCT suggests that low-dose clonidine, that is doses less than 0.3 milligrams a day, prevent myocardial ischemia. It may not increase the risk of clinically important hypotension remotely to the degree that the beta blockers do. Further, people may be more responsive to the actual treatment of it when they do become hypotensive. Perioperative clonidine is used infrequently in the perioperative period. Perioperative aspirin trials, they may prevent vascular death. The effect on myocardial infarction is actually unclear. In fact, the largest trial done to date with myocardial infarction showed an excess of myocardial infarction in people getting aspirin. And I know off the top that seems so counterintuitive to everything that people will believe, and I personally hope it's wrong, but it's possible it's true. How it could be true is that there is zero doubt aspirin increases the risk of bleeding. To the extent that some people are right and that a dominance of perioperative myocardial injuries start off as supply-demand mismatch, to the extent that that's true, aspirin won't prevent the events, but through excess bleeding could increase the events. We will see how that plays out. I think most people will agree that the use of perioperative aspirin is hugely variable. So in Poise 2, which I'm going to tell you about in a moment, we had no pushback on clonidine. We had tons of pushback on aspirin. Some centers refused to participate because it was unethical to give it. Some centers refused to participate because it was unethical not to give it. We had strong feelings on both sides of the equation regarding aspirin. So Poise 2, the primary objective is to determine the impact of perioperative low-dose clonidine and separately low-dose aspirin on the composite endpoint of death and non-fatal myocardial infarction, which will be moving to MINS at 30 days. It is a blinded factorial randomized controlled trial, 10,000 patients. We've currently recruited over 8,000 patients. We're on track to finish this fall. We hope to report the results early in the new year and share the results at that time. So It's not clear how we can clearly prevent these events. That being said, I think there's lots of reason for hope. We're also hoping in Poise 3, we're hoping to study ivabradine, which some of you may be familiar with, but it's a drug which lowers heart rate and has zero effect on blood pressure, which sounds very attractive for the perioperative setting. It maintains cardiac output. And also at the same time factorializing tranexamic acid. There is no doubt that the bleeding is also a significant problem that we confront in this setting. So hopefully that'll be how Poise 3 transpires. So I'm confident that we are going to find a way to safely control the sympathetic system, and I'm confident that, in fact, we and others are going to find pathways to actually prevent these events. But collectively, everyone needs to come together on these things, because trials don't happen because of people like me. They happen because of collectives. It takes a huge community to make these trials happen, and they are the community trials. They're not individual trials, and the only way we can get these answers is by people coming together to address them. Separately, the issue is, should we measure troponins post-operatively? MINs that would probably go undetected without troponin monitoring, that is, MINs without chest discomfort or other possible symptoms that would have triggered potentially the surgeon to order troponin. 84.2% of the events. So almost, if you don't measure troponins, you're missing almost 85% of the prognostically relevant troponin elevations after surgery. You're only picking up 15% of what happens. And that's why, to a certain extent, when people think in their clinical practice, yes, everyone will say perioperative myocardial injury is an issue, but they don't actually appreciate to what extent it's an issue, because they're missing 85% of the events. Because globally, there's a shift happening, but the majority of centers don't monitor troponins. So they're only picking up the tip of the iceberg of what's actually happening. These, once again, because they are asymptomatic, does not make them benign events. Their risk of mortality at 30 days is 9% without having any ischemic symptoms. If they didn't have the event, the risk of mortality would be 1%. So these are not benign events. We should not be lulled into a false sense of security because the patient is not clutching their chest and complaining of symptoms. Based upon the VISION data and the Poise 1 data, the third universal definition of MI, with recommendations from the European Society of Cardiology, American Heart Association, American College of Cardiology, World Heart Federation, is now recommending to measure troponins perioperatively in high-risk patients undergoing non-cardiac surgery. Now, the guidelines don't define what is high-risk non-cardiac surgery. And I mentioned earlier, Giovanna Laurati will be doing a presentation tomorrow looking at some of the cost-consequence data from VISION. And certainly, in terms of a practical group that we're recommending and we're putting in place in our institutions and in centers doing studies with us, anyone age 65 or greater, or under 65 with known vascular disease, carotid, coronary, or peripheral, we measure troponins on day 1 and 2 post-op. If you consider screening for colon cancer, breast cancer, any of these things reasonable, this looks incredibly attractive relative to those. And importantly, we're not talking about death in the coming 5 to 10 years. We're talking about death in the coming weeks. So we think it's a reasonably compelling case why, in fact, we should be measuring these troponins, and now there's a guideline to support this. The other issue is we do have data from Poise that does suggest, so in Poise, we looked at all the people that have myocardial injury, and then we looked to see what treatments they did receive, and then we did risk adjustment, observational, but risk adjustment to say which one of these drugs look protective. Aspirin and statins had mortality advantages at 30 days. Now, that doesn't prove it because it's not an RCT, but at the same time, it is not rational not to believe that signal. We have so much overwhelming evidence that once people have myocardial injuries in every other setting, if they get aspirin, they get a statin, they have big benefits, that it's not rational in this setting not to believe that happens. What does happen, though? So this is data that includes American data, Canadian, European, Asian data, South American data. We look at the use of these drugs in the perioperative setting. So if you look at the people who have MINs that don't have ischemic symptoms that would go missed if you didn't measure your troponins, a third of them are getting aspirin. A third of them are getting a statin. Less than 50% are getting an ACE inhibitor. That's a tragedy that, we should be making sure these patients are getting those minimum drugs. And that's negating the whole point of even just keeping a closer eye on the patient, getting them seen by someone and followed up by someone in medicine or cardiology, which it's almost for certain that likely has its own benefits. And I can point to individual cases because in our center, cardiology is cardiology and perioperative vascular medicine. So we have a program where we basically co-manage anyone coming to the hospital throughout the perioperative period with any cardiovascular risk. And I can easily show you a case where I think most people would agree that because we picked this up and what happened to the patients and what transpired,
it's almost for certain a change in the trajectory. We also do have data from our service, risk-adjusted, that we've in fact decreased myocardial infarctions and heart failure by putting in co-management of these patients. So I think that there's many reasons to believe that in fact these patients will benefit from this. The other thing is, we ask people, will people be agreeable to do an RCT testing aspirin versus placebo, statin versus placebo after you have myocardial injury? Despite the fact that only a third are getting it, no one would agree to do the trial. And the truth is, I would not be crazy about my loved one going in the trial knowing that data, because it's just not rational in this setting to think that that's not, in fact, an effective treatment. So we need to focus on the other options that, we should be testing. Which brings us to the issue of what is the pathophysiology of perioperative, so we can think through how do we want to treat this. So I put forward to you that there's growing evidence. I will say this. I think a majority of people writing in the area of perioperative medicine say that it's all or overwhelmingly supply-demand mismatch. So I just want to acknowledge that point. But I will now put forward to you that I think there's a growing body of evidence that suggests they may not be that different than people in the emergency room. That in fact these may be more commonly thrombotic events than what people expect. There's no doubt surgery creates the perfect environment. It's procoagulant, pro-inflammatory, elevated catecholamines, perfect milieu for causing thrombotic events. A cath study just recently published out of Brazil. Consecutive patients who suffered a perioperative acute coronary syndrome, so MINS patients, okay, non-cardiac surgery. And they took randomly selected non-operative myocardial infarction, so people coming through emerge, and randomly selected people coming to the cath lab without an acute event, but being referred for underlying angina. And then what they did was they had people blindly read the cath, not knowing what category they're in, to look to see what was underlying pathophysiology within these caths. Now, one thing I'm also going to acknowledge, our ability on routine angiography to see thrombus is limited, and to see plaque fissure and rupture has limitations. But to the best of the ability, people blindly reading it, this is what they saw. An Ambrose type 2 lesion suggests underlying plaque fissure and rupture. And what you see is that in the perioperative MINS ACS patients, 45% have this. The non-operative ACS patients, 57%. Whereas the stable, the CAD, just the angina patients, it's 16%. The perioperative patients look much more similar to the emergency room MI patients than they do to the stable angina patients. Further, the time to cath in the perioperative patients is 5.5 days, whereas it's 1.3 days in the non-operative MI patients. The quicker you get to the cath lab, the more likely you are to see the actual findings. The longer you wait, the more you get resolution of findings, which suggests that, in fact, if they had been going the same time, they may have had exactly the same number, even more in the perioperative cases. But one thing that is consistent across all the studies is the outcome. The outcome is very different. So 15% of the people in the perioperative MINS patients dead in 30 days, whereas people showing up and emerge, 4% are dead in 30 days. Now, there is no doubt all over the planet, certainly if we look at developed countries, the average mortality in people presenting to emerge in most centers who make it to emerge with an MI is in the range of 4 to 6%. Most centers are probably in the range of about 4–4.5%. We jump all over those patients, and it's appropriate, and I think we do very good things for those patients. The irony is the patients who have a much worse outcome are unequivocally ignored. 4% of the MINS patients, including US data, Canadian data, in the centers that are involved in our big studies like Vision and that, go to the cath lab. I'm not saying that's wrong. What I am saying is profoundly different. When we talk about the drugs, a third are getting aspirin, a third are getting a statin, less than 50% are getting an ACE inhibitor. So remarkably, these actually look like the non-operative MIs 25 years ago when we had no idea what we were doing in cardiology. It was basically before we started treating them. And that's why I am really hopeful as we move into an era of saying, let's identify them, let's start using basic things that we know and start studying other things that we can try to test, that we can really make an advancement on the arterial side in the same way that people have made an advancement on the venous side in the perioperative setting. We're doing a study right now where patients who get a perioperative MINS, MI, after non-cardiac surgery, and people come to the emergency room with MI, we rush them to the cath lab, and we do an angiography. And what this picture is showing you is that there's new technology with angiography use. It basically uses infrared light. And with infrared light, for the first time, we can actually really see thrombus, and we can actually see the endothelium with enormous precision to see if there's plaque fissure and rupture. This is a patient who had elbow surgery. In the study, 2 to 3 days later, troponin goes up. We take them to the cath lab. You're seeing their LAD. And what you're seeing in this slide, in the upper portion here of this is thrombus in the LAD. I guarantee you that 99% of people would have looked at this case and said it's a patient with elevated troponin after surgery, nothing exciting going on, this is supply-demand mismatch. I just want to tell you in the study, it's still early days in it, but there is absolutely zero doubt. There's unequivocally lots of patients who get thrombus. And the reality is there's also people come through eMERGE who we had all unequivocally said it's a thrombotic event where we do this and we don't see thrombus. I believe both categories are heterogeneous. And importantly, even if it does start off as supply-demand mismatch, it's not the initial event that kills most of the patient. It's the recurrent event in the weeks to months later, which almost for certain is going to be thrombotic events, which still holds out hope that antiplatelets, anticoagulants, other therapies are going to help to settle down those plaques and prevent those events. But we need to start treating them. We need to start testing these patients. Now, there is overwhelming evidence, we have antithrombotic evidence improves outcomes after non-cardiac surgery. In Poise, as I mentioned, in the patients who did suffer MINS, when we looked to see aspirin risk adjusted for other drugs, other things, it did look protective. There is no RCT evidence at this point for any intervention in this setting, but there's several basic drugs where I think it doesn't make rational sense not to be giving the patients these drugs. There is very overwhelming evidence of the short-term impact of antithrombotics in the non-operative setting. So we have both an acute non-ST elevation myocardial infarction and ST elevation myocardial infarction, overwhelming evidence that anticoagulants work. So in a standard of care, we use it all the time, everywhere on the planet, in people presenting with non-operative MIs. Also, there is overwhelming evidence that anticoagulants work in the long-term post-MI in the emergency room, despite the fact that we rarely use it. Now, the reason that we rarely use it is that it's so much easier to use aspirin and Plavix. Warfarin is a pain in the ass. It's a really difficult drug to use. So because aspirin and Plavix has come along, people use that. But that does not negate the fact that anticoagulants are effective. So this is meta-analysis looking at warfarin and aspirin versus aspirin alone in people who've had a myocardial infarction through the emergency room. And what you see is that there's a reduction in death, MI, and stroke, but there's no doubt there's an increased risk of bleeding. But they do work. When we think about MINS, there's supportive evidence that an anticoagulant may be beneficial in that we're borrowing from data in the non-operative world. We have data that does suggest that a number of these events are starting off thrombotic. And further, we have evidence that, in fact, it makes rational sense that the recurrent events are thrombotic. So hence, it's not a crazy leap to think that an anticoagulant may work. The issue is what agent to choose. Now, I'm going to tell you about a trial that we've just launched. We're using Dabigatran. I'm going to explain why we're using it. But one point I want to make very clear. In testing Dabigatran, I'm not suggesting for a second that there's anything magical about Dabigatran. I think any anticoagulant has the potential to work. The real issue with every anticoagulant is choosing the right dose. So as an example, a study done at my center where they compared fondaparinux versus enoxaparin. They showed a mortality advantage to fondaparinux. I suspect fondaparinux is not better than enoxaparin. The issue is they were smart enough to choose the right dosing, which I think led to less bleeding, less thrombotic events, and that's why you see this mortality advantage. So I really think with most anticoagulants, although there's differences where they hit the pathways, the real issue is how much data do you have at hand that's going to likely inform you about what might be a safe dose but still achieves effective anticoagulation. Further, by testing an anticoagulant, we're not suggesting for a second that there's not a need to test dual antiplatelet therapy or test other agents. There's a need to test a whole bunch of things. But you have to jump off somewhere in testing something, and it just has to be that you think it's a credible thing to test and try to figure out where can we start making impact in this area because we've had no RCTs. The reason that we chose Dabigatran, and I want to be clear, we chose Dabigatran 110 BID. The reason is it's non-inferior to warfarin in preventing thrombotic events. So importantly, you may have heard that, in fact, there was a meta-analysis that suggested that, in fact, Dabigatran had an excess of MIs. And a lot of people jumped to the conclusion Dabigatran's causing MI. And what they ignored in the meta-analysis is that Dabigatran had a mortality advantage. So even if it was true that it wasn't as good as preventing MI, but it saved lives, most patients would probably prefer that we chose that drug. Secondly, is that you're getting into a competing risk problem. If a drug saves more lives, more people hang around to get non-fatal events, which then can shift how many events you're seeing that are non-fatal. But importantly, with the 110 dose compared to the 150 dose, the 110 dose did not have an excess of MIs, but importantly, it actually had less unstable angina. You don't see any excess of unstable angina. Or sorry, you see actually lower unstable angina with the Dabigatran 110. Dabigatran 110 compared to warfarin results in less major, life-threatening, and importantly, intracranial bleeding, and compared to the 150 results in less major and GI bleeding. This is the meta-analysis that I just mentioned that was published in the Archives of Internal Medicine. And as I said, the real issues is that dabigatran in the meta-analysis has a mortality advantage. There was more myocardial infarctions, and it is actually very possible that warfarin is more effective in preventing MI in this non-operative setting with this data. All that being said is that if in fact it's saving more lives, it's still a better choice. But importantly, you have a competing risk problem where you have more people hanging around to actually potentially get the events. And this is sort of analogous to when people were studying atrial fibrillation, they compared warfarin versus aspirin. In the trials, aspirin had more strokes. No one jumped to a conclusion that that meant aspirin was causing strokes, which it wasn't. It was actually preventing strokes. It just wasn't as good as warfarin. So it's an irrational jump, I think, that has happened in the community to say, wow, could dabigatran be causing MI? And in fact, there was a publication just about 2 weeks ago that came out and said it's a study that came out of the Netherlands, observational, big study, and showed a 70% reduction in myocardial infarction with dabigatran compared to warfarin. I don't believe any of them. I don't believe that, in fact, an anticoagulant biologically can cause MI unless it causes more bleeding. Because basically, you have to cause enough bleeding that you get people off of the drugs, off the antiplatelets, put them into prothrombotic states, transfuse them, drop their hemoglobin. The irony is dabigatran causes less bleeding. It's not a biologically credible comparison. So we're also testing in the managed trial omeprazole, and the reason for this is that major bleeding after MI increases mortality and major vascular complications. In MINS, 7.6% of patients suffer a GI bleed in the first 30 days. ASA and dabigatran increase the risk of gastrointestinal bleeding and dyspepsia, and omeprazole reduces the risk of GI bleeds, dyspepsia, and increases drug compliance. For all these reasons, there may be benefit to it. So the primary objective in MANAGE is among patients who have suffered MINS after non-cardiac surgery and are followed on average for 1 year, determine the impact of dabigatran 110 BID versus placebo on major vascular complications, and omeprazole 20 milligrams a day versus placebo on major upper GI complications. It is a partial factorial. Everyone goes into dabigatran. If they're on a PPI, they're out of omeprazole. If they're not on the PPI, they get randomized into the omeprazole part of the arm. Sample size is 3,200 patients. We've just started the study. It's going in Canada. We now have the FDA approval. It'll be starting in the States. We hopefully will have the European approval in the next couple of weeks. And there's several other, it'll be done, I think, in about 24 countries in the end. 28 countries, 160 centers. So in conclusion, troponin is a strong independent predictor of 30-day mortality after non-cardiac surgery. Prevention strategies still are unclear. There is hope that controlling the sympathetic system looks clear that it is beneficial. The issue is being confident we can establish a way to do it safely. The third universal definition of MI is now recommending to monitor troponins after surgery. Worldwide, there's likely now 8 million cases of MINS happening globally. If you look at the vision data and extrapolate, because it's a representative sample, it's an enormous population having these events. The managed trial will inform treatment and pathophysiological issues. The status quo is not acceptable, but we really all need to come together as a community if we're going to address this problem. And as I said, it really only happens because everyone gets behind these studies, and they are community studies. They're not individual studies, and it's the only way we can get these things done. I do hope people will get involved in either leading them or getting involved with groups doing studies in this area, because it is a really big problem that's going to confront our patients and be the dominant cause of why, in fact, your patients are going to have mortality in the short term after surgery. Thanks very much. We started about 7 minutes late, so I don't know if we can take 1 or 2 questions if anyone wants to ask anything.
Dr. Devereaux, thank you for introducing us, or at least for introducing me to the MINS concept, which I'm sure we're going to hear a lot more about. Very narrow question. On your list of predictors of preoperative predictors of mortality, there are various surgical procedures. Vascular surgery was not on the list. Is this, in essence, a proof of concept that we're already doing the right thing, or why not?
Yeah, so vascular surgery now drops out. So what it's suggesting is that the patients and their underlying comorbidity is what drives the events with those patients, as opposed to something unique about vascular surgery. The one thing that we are witnessing, there's absolutely no doubt, the event rates with vascular surgery relative to, let's say, orthopedic surgery is rising, vascular surgery is coming down because of the endovascular approaches. Now, these people still do poorly in the intermediate term, and they still have events, but it does not appear that the surgery itself appears any more predictive than the other surgeries anymore. And I think that that relates to the fact that we've switch to a much more endovascular approach. So it is their underlying disease states in those patients that now drive the events, not the surgery itself.
No one else runs to the microphone. I'll ask another. Are you at liberty to give us a perspective on where this Polderman's problem is going? And you mentioned statins. The decrease 3 looks like very convincing evidence of the perioperative benefits of statins in vascular surgery. Can we accept the result, or are there going to be retractions? Are you at liberty to tell us what you know about this?
Well, I mean, what I end up having is people endlessly sending me documents and asking me to comment, and the media asks me to comment. What I've said up to this point, because Don Poldermans and we debated several times publicly, and obviously we took very different positions on a number of points. I was surprised by it, even though I thought his results were way too good to be true all the time. I didn't think there was fraud. That being said, when you read the reports that have been submitted and they're in the public domain by MS, you read the reports, it's really difficult to believe that, in fact, there's not a whole lot of reasons to be suspicious about all the research. You can't say that we now have studies towards the end of his career where data is clearly made up, but we think that the stuff earlier, we're not going to look at it as closely, but or we can't find the data, but everyone seems to say it's okay. In my experience, we found fraud in Poise 1. I think the likelihood that someone starts off a career with high integrity, doing things right, becomes established, renowned, really well known, which is true. Don, he was extremely well known. That all of a sudden later in their career they'd start making stuff up, I find a difficult leap to understand why that would ever happen. You read it, there's so many things that are listed in terms of they can't find this, they can't find that, one person saying this, that it really raises suspicion. And I think to a great extent, the issue that's happened with it is that a lot of the community also, he published so much of what has been written and based upon was based upon his research, that people feel very uncomfortable to say, we're just going to dismiss this. At the same time, it becomes, the problem with credibility in research is that once it's gone, it's gone. And I think, there's real questions about all of the data. And I think a lot of things, too, is that Don told people stuff they wanted to hear. Don Poldermans told people that beta blockers were a panacea. His trial suggested that there was a 100% reduction in myocardial infarction and an 80% reduction in death. People wanted to hear it. People wanted to believe it. People wrote guidelines saying that's true. People want to believe the statin story. I would like to believe it too, but what I put forward is we owe it to our patients to be confident about data, because the problem is, it's like the example I gave you this morning with my mother. Sometimes we have it wrong. And there is no doubt that it is possible that it's simply dosing and other things in Poise that caused our complications. But it appears consistent even with the studies that use half the dose in terms of stroke and even mortality. So that it makes it very difficult to believe the data. And I just think it's a very sad story. It's very unfortunate for perioperative medicine that this has happened. But I think it's very difficult to say that we're going to accept one part of the data because we just want to believe that story. And we're acknowledging that late stuff clearly had negligence and clearly had stuff made up, and they can't find half the data on most of it, but we're sure the other stuff's okay. I think that's a really difficult position to be in, and I really think it's a sad moment for perioperative medicine. But I think we learn from it. I think the big thing is we also need to recognize it's a big problem to have these small trials with these very big events. They're not believable. We need big trials with tons of people involved internationally where there's great oversight. It's not individuals. And you read the story, like it's a crazy story. A bunch of the people who are famous cardiologists involved with Don, this all breaks. They're on 150 publications. They barely know him. They barely know anything about what happened. They just said this guy was doing research. He sent me papers. I'd sign off on them. I assumed it was all being done right. It's a remarkable story that, it's a sad, I think, reflection on the fact as a broader community, he told people things they wanted to hear, so people didn't necessarily question how extreme the results were. And secondarily, there was people involved who all of a sudden pretend that they knew nothing about anything, yet everyone seems to be claiming that it's obvious that there was a lot of things going wrong and questionable. And I think, we have to learn from it, but I do think We need large, big international studies with lots of oversight so we can be confident in the results and not make the same kind of mistakes. Anyways, thanks very much.